Last year, I had to defend EPP, extrapleural pneumonectomy, and as you already noticed, this is almost an obsolete procedure. And that's the reason I think that in the perspective of cardiothoracic surgery, so the book you got within your program bag, they moved it to the last chapter. So probably that's also the reason I give the last talk of this session on surgery offers the best outcome. So first of all, let's look at precise definitions of surgical techniques, because that's a mistake we made in the past. It was not really clear what kind of operations we were doing. And then we look at some surgical studies, some initial landmark trials, our ERTC trial. The MARS 1 was already addressed. And then we look at some recent guidelines and conclusions. So what I would like to do first is give precise this definition. So you already heard that as surgeons we select patients, but as I mentioned this morning, it's the same as personalized therapy, what the oncologists are doing. You select patients with a specific mutation, and then you give adapted therapy. And especially in continental Europe, also in the US, it's difficult to perform randomized trials with a surgical and a non-surgical arm in those patients who are functionally and technically operable. So the reason that there was a lot of discussion about what kind of procedures are we doing in surgery, the IASLC and EMIG made a consensus report in 2011, giving precise definitions of what we are meaning. So EPP means en bloc resection of the parietal and visceral pleura, so this includes the whole ipsilateral lung, and pericardium and diaphragm if necessary. So this is a macroscopic, complete debulking operation. And I agree that there is no curative surgery in mesothelioma, but curative means that you're cured completely and that nothing will ever come back. That's the definition of cure. But even for lung cancer, we do not cure our patients. In contrast, extended pleurectomy-decortication, formerly called radical, is not really radical in that sense that we do not remove everything, also on a microscopic level. So it's resection of the parietal and visceral pleura with the diaphragm and or pericardium, meaning that all gross tumor has to be removed, so we obtain a macroscopic complete resection with residual tumor of less than 1 centimeter. So this is important when you look at data of extended pleurectomy-decortication. And a classical pleurectomy-decortication is resection of parietal and visceral pleura without diaphragm or pericardium, and all gross tumor was removed. In contrast, a partial pleurectomy is partial removal of parietal or visceral pleura for diagnostic or palliative purposes, as in the Mesothelioma trial. So, some landmark trials. We know from mesothelioma, when you look at long-term survival data, that single modality therapy, radiotherapy, surgery, or chemotherapy will not be effective. And the problem is that there is a high local recurrence rate of 80%, even when you add post-operative radiotherapy. One of the first combined modality studies looking at surgery, EPP, or pleurectomy-decortication, followed by post-operative radiotherapy, was published by Memorial Sloan, Valerie Rush in 2001. And they could decrease the number of local recurrences to 13% by adding post-operative radiotherapy. As already mentioned, we don't have any large randomized studies looking at surgery versus non-surgical treatment in mesothelioma. I would like to draw your attention to some survival data. This is a well-known study, the Vogelsang study, randomized phase 3 study, more than 450 patients, randomizing the patients between cisplatin and cisplatin with pemetrexed. As you know, this became standard chemotherapy for mesothelioma. Looking at the survival data, you can see that when you give chemotherapy by cisplatin only, you have a median survival time of 9 months, and try to bear this in mind. This increases by 3 months only when you add pemetrexed. So this became standard chemotherapy. The SAC group, so the Swiss Group for Clinical Cancer Research, introduced induction chemotherapy as for lung cancer, but they used cisplatin and gemcitabine. At that time, the Vogelsang study was not really known at that time. So those patients completing chemotherapy had EPP followed by radiotherapy in cases there was an incomplete resection or some remaining areas at risk. 37 patients had complete resection, but most of them had post-operative radiotherapy. Mortality, and look at these figures, 3.2% 90-day mortality, try to bear this in mind, More complications, so higher morbidity, and especially after induction chemotherapy, you pay a price by empyema and bronchopleural fistula. But median survival time, 26 months. Afterwards, they performed randomized phase 2 trial of induction chemotherapy, followed by EPP, with or without the addition of PORT, but PORT, so post-operative radiotherapy, had no significant effect and was not and should not be routinely used after induction chemo and EPP. Then came this study by Dr. Flores, looking at a total of 663 patients who had EPP or pleurectomy-decortication. Again, EPP had a higher mortality, 7%, compared to pleurectomy-decortication, 4%. And rather surprising, when they made a multivariate analysis, those patients who had EPP versus pleurectomy-decortications had a higher hazard ratio, so a higher risk of dying than those patients having pleurectomy-decortication. At that time, it was said probably this is only selection bias. But some other data came up. And looking at prospective studies, our EOTC 08031 trial looked at those patients with clinical T3 and 1 who had induction chemotherapy with cisplatin pemetrexed, followed by, so all the patients had EPP, followed by post-operative radiotherapy. So this is really the toughest treatment a patient can have. Looking, I don't give the details of this study, but looking at the survival data, overall median survival time was 18.4 months, and this is an international multi-center study. The primary endpoint defined as success of treatment, meaning patients had the 3-modality therapy within predefined time limits, the primary endpoint was not met. Usually because the patients could not have the treatment as predicted or as stated by the specific time limits that we put on ourselves. And then the MAS-1 trial has already been discussed, but what should be mentioned is, so it's a feasibility trial that was published, but look at the data. First, they evaluated 112 patients. Eligible were only 57 and randomized only 50. So this is also a very highly selected group of patients. And those were randomized between EPP and no EPP. The patients having EPP should have undergone post-operative radical radiotherapy. But in fact, only 16 patients completed the EPP surgery, and 3 of those patients died, giving a very high mortality. But I don't think you can judge a procedure on 16 patients only in a highly selected group of patients. And only 8 of them received radical radiotherapy. So looking at the power of this study is very low. In fact, there was a feasibility trial showing that you could randomize patients, so the survival data are not really valid, and especially the mortality data. So this is the highest mortality that has ever been reported for EPP. That's the reason I showed you the other data. And it took them 3 years to randomize 50 patients. And as already mentioned, you can see that the survival curves, in fact, are very parallel, but you pay a very high price in the surgical arm due to the extremely high mortality, much higher than in all other studies of EPP. So what do recent guidelines state? And in fact, they leave the door open for pleurectomy-decortication or, in some cases, even EPP. This is a systematic review, published in 2014, looking at EPP versus extended pleurectomy-decortication. And you can see the overall mortality for EPP is a bit less than 7%, and for pleurectomy-decortication is less than 3%. And look at the survival data, 22 months for median survival time for EPP, and between 13 and 29 months for extended pleurectomy-decortication. So again, although these are selected patients, but I cannot believe that surgeons always select those patients who will have the best prognosis anyway. So there's a trend now towards extended pleurectomy decortications that we do the same in our center and reserving EPP only for those patients having massive involvement of lung parenchyma. These are data from the IASLC, so it's a retrospective data, but including more than 3,000 patients from 15 centers and 4 continents. And rather surprisingly, when you look at the survival data, you see here stages 1 and 2, stages 3 and 4. But the best prognosis, it's a retrospective analysis, but rather surprisingly, the best prognosis was noted in those patients with stage 1 who had EPP. So is this procedure to be condemned completely? Recommendations from the Australian guidelines state that cytoreductive surgery should only be used as part of multimodality treatment and restricted to institutions with a high surgical experience and high volume of cases. There's an important issue also that those are not very easy procedures, and as you have seen, there's a high morbidity after those operations, so those should be performed in centers with the necessary experience. And only patients with favorable prognostic features, histology and staging, should be referred for radical treatment. And again, a multidisciplinary team with sufficient experience should provide advice on each individual patient before embarking on trimodality therapy. And those patients who progress under induction chemotherapy have a very poor prognosis anyway and should not undergo radical surgery. The ESMO guidelines state approximately the same. What are the indications for surgery? So palliation of pleural effusion when chest tube drainage is not successful, as we have heard. To obtain more diagnostic samples, also the role for surgeons, and to be part of a multimodality treatment, preferably as part of an ongoing study. And you can perform macroscopic complete resection, not microscopic, but macroscopic, by means of pleurectomy-decortications or EPP, if you have the experience, and this is an optional treatment. And lastly, you already heard of the Mesothelioma trial, of course. So the role of surgery is not only to provide palliation, but in some cases we improve also quality of life. So in conclusion, mesothelioma remains a highly lethal disease. The surgeon has a role in diagnosis, staging, palliation, but also treatment, so macroscopic debulking surgery. Combined modality treatment is indicated in early stages. We don't know what the role is of induction versus adjuvant chemotherapy, and we'll address this in a new ERTC study. There's a shift towards extended pleurectomy-decortication when you can obtain a maximal debulking procedure. Is there really a survival advantage of trimodality treatment remains an open question, but it will be difficult to do randomized trials that are sufficiently powered. So in fact, we should go for personalized therapy for every patient, and further trials are certainly needed. Thank you for your attention.